Welcome to Parallax by Ankur Kalra, a podcast produced by Radcliffe Cardiology to bring you a new angle of all things cardiology and the best from the US Cardiology Review. Published every second Monday, Ankur Kalra, MD, interventional cardiologist at the Cleveland Clinic in Ohio, USA, speaks with legendary cardiologists, reviews late-breaking trials, and interviews authors of our latest and best US Cardiology Review articles. We call them #audio articles. Parallax is the effect whereby the position or direction of an object appears to differ when viewed from different positions. So this podcast is your fix of reliable updates on all things cardiology by someone from a non-traditional background who is always looking at the industry from a new angle. Now, here's your host, Ankur Kalra, MD.
Hello, everyone. Welcome back to yet another episode of Parallax. I have the honor and the privilege of having with me a very special guest today on the show. He is someone who I consider a friend, also a mentor, someone who I look up to, personally and professionally, as to how he has led his life in both personal and professional spheres. He also has been, sort of a guiding light for me when he has reached out to me personally, and recommending different aspects of, both practice of medicine and cardiology as well as practice of life. He has reached out to me on several occasions, looking out for me. So I really look up to him for many things, not only in cardiovascular medicine, but also in life. My guest is Joao. Joao, I hope I'm pronouncing your name correctly.
Yes.
Dr. Calvacante is the director of cardiac magnetic resonance imaging at my alma mater, the Minneapolis Heart Institute, an institution which is very close to my heart. He's also the director of structural computed tomography laboratories at the Minneapolis Heart Institute, and the director of the imaging core laboratory. As we all can see, he's very involved and very occupied and very busy, and has done some incredible work, meaningful work, both clinically as well as in clinical research in the imaging space. So, Joao, welcome. Thank you for being on the show.
Thank you very much, Ankur, for such a kind introduction. And it's a true privilege to be here today with you and spend some time discussing about a podcast about myself and about our pathway as friendships as well. And, about a podcast that I have been a friend of it. I think you bring several aspects about, we as human beings and, as care providers, we have a personal history, and I look forward to this discussion tonight.
Thank you. Yes. So, we would like to get started by asking you about your journey into who you are today. Tell us a bit more about, your childhood, growing up. What were some of the circumstances that led you to pursue a career in medicine and then in cardiology? Who were your role models growing up, and who are your role models in the current era of medicine and cardiology? So looking forward to hearing more about your personal story.
Yeah, no, thank you. I think it's a story of many stories. So I truly believe that every generation tries to do better than the predecessor. So, I was born and raised in Brazil, in a city called Fortaleza, which is the capital of the state, Ceará. Fortaleza is on the northeast coast of Brazil, and it's about a 3.5 million population. And my parents, my father is a physician, retired physician. Now he's a psychiatrist. And my mom was a social worker with a special interest in understanding aging. And so both of them were academically very motivated, and had decided to, in the late 70s, and specifically 1978, just 6 months after I had been born, to go to France. And so my father got a scholarship to study psychiatry and do his PhD in psychiatry in the city of Lyon in France. And I was, then taken and grew up there until I was 2.5 years old. He completed his PhD and then moved on to Brussels in Belgium to study anthropology. And you could think that, what is psychiatry doing with anthropology for a physician? But it has a lot of actually common background, because it's as important as it is to make the biological diagnosis, is to understand the social, cultural background of the patient and the environment in which he or she is. So case in point, for example, a depressed patient in Brazil or in the United States will behave differently than some other cultural backgrounds and beliefs, for example, in Asia, Japan, or India, or in other places. There's a social background support that is important to understand, and that's part of the healing process as well. And so he was quite intrigued by that. And that was part of also going beyond just the biological part that he had studied by doing that. And so we lived in Brussels for about 3 years. And after that, they decided to return and back to Brazil. And we were speaking Portuguese at home, but my main language was actually French. And then I had to learn Portuguese after I got back. And it's funny that I remember some conversation with some of my cousins, saying, "What language is it talking? Because we cannot understand." And it was that way that we kind of got introduced back to the Brazilian culture and grew up there, and always had my father as one of the role models. He used to take sometimes phone calls and treat patients, and did a lot of psychotherapy too. And medicine for me was something that I enjoyed, but I also enjoyed the human aspect of the patient and the disease. And always, as growing up in Brazil, like music, and I still play music. And music for me was also a means to get introduced to the American culture, and lots of the 90s rock bands, and played in some bands in Brazil. And I wanted to come to the United States and do an exchange student program, but it was hard for him to be convinced that I could come to the United States. There was some resistance, and I had to pretty much lobby. My mom was more convinced, but he wasn't. And finally, he allowed me to come, and I came in 1994 to a small town in Wisconsin, a city called Bruce, Wisconsin. And it was a small town, little less than 1,000 people. There was nobody there other than me, as from medical graduate in the middle of January. So the contrast about the weather, leaving the Northeast coast, 80 degrees all year long to minus 20. But I was, that was my purpose. That was, the way to get introduced and immersed into the American culture. And after 6 months, I came back to Brazil, and, a little bit of a longer hair. And, I was, really passionate about music and my experience of living here for 6 months, graduated from high school. And when I went back to Brazil, there is this big exam that you need to get into, which is then very competitive to get into the public universities there. And I wanted to, instead of pursuing medicine, I wanted to do psychology, actually. And he was quite perplexed, with that, and said, "How is that possible?" That, I knew that the United States was going to screw him up, in the back of his mind. That was something that he kind of probably was correct, But he said, if you like psychology so much, why don't you go do medicine again? Because there you can see psychology, you can see psychiatry, and you can see so many things. And I think that was probably one of the single best advices that he has given to me. I guess I could have been a successful and passionate psychologist, but probably a little bit more limited into what I could have done. So study hard, and then finally got into university. And finishing the 6 years there in Brazil, I had the chance to do an exchange student program in Detroit, Michigan, in urology. And I knew that I did not want to do surgery, but that was the opportunity to do some rotations there. And then that's when I got first introduced to the American medical system. And you used to have textbooks in which I could read about and have practice, get this test, get this lab, get this exam. But I was never able to do that with the resources that we had that were so limited back in Brazil. And finally, I decided to come and apply for the US MLEs and take the journey here, and was lucky to match at the Henry Ford Hospital in Detroit, Michigan, and I started my journey into internal medicine. And then, after that, chief residency and then cardiology at Henry Ford. And I could have, finished that and then start practicing, but I still had this very deep and still, pursue that with me, passion about cardiac imaging, which was just at the beginning at that time. There was obviously some cardiac MRI, but CT was kind of at the beginning of it. And at that time, there was no training in imaging at the Henry Ford, but there was one at Cleveland Clinic. Which is interesting that's where you were practicing now. So,
Yeah.
I went back to Cleveland, and that's where, my daughter was born. The boys were born in Michigan during the years there, and met my wife, and the girl was born in Cleveland, Hillcrest Hospital, and then we finished the 2 years of advanced cardiac imaging, which actually opened for me a palette of so many opportunities. That was the beginning of structural interventions. TAVR was, already being done, left atrial appendage closure and some mitral clips. And it was Dr. Samir Karpati and Murat Tuju, both of them scrubbed in the cath lab, and us providing TE guidance at that time. And a lot of this structural TAVR CT was, at the beginning of the understanding, and cardiac MRI was full force. And after that, then my first job into an academic job at the University of Pittsburgh, where I stayed for 6 years and became associate professor. And then this opportunity that came out of the blue here to Minneapolis Heart Institute, which is my home, and a phenomenal group that I cannot say enough good things about.
Yes. So, phenomenal journey, really. A lot of similarities if I were to, recite my story. Growing up in a similar culture, my father is a cardiologist, and, I think as far as I can remember, I always wanted to be a physician. And, similar to yours, had to really persuade my father to allow me to come to the United States to pursue further training and advanced training in cardiovascular medicine. And for the longest time, my plan was to go back until Cleveland happened. And, it's the city that has given me both my boys. Actually, it's funny you mentioned Hillcrest Hospital. That's where our second one was born now, about 8 weeks ago. So, it's just a lot of similarities. But, I agree with you. The group at Minneapolis Heart Institute is just a phenomenal group of cardiologists. There's a lot of camaraderie, and I think the culture is very healthy, is very collegial, and I certainly relish my memories of time that I've spent with that group, and hold each one of them very fondly in my heart.
That's so nice to hear. Yeah, I am really blessed and thankful for every day, every moment of being part of this, the support and the vision and the drive that lots of our members here have. It's second to none, and I think that is contagious, and it can only do better. I am really honored to be part of this, and as some things happen sometimes completely unexpected, and that was the circumstance here, and I have to be grateful for that.
Yeah, no, absolutely. I think also I'd like to believe that good unexpected things happen to good people, and you certainly are one of them. So it wasn't a surprise to me when you brought that up. When I think I saw you now I think it was about a couple of years ago,
Yeah.
at the CVI meeting in Denver.
Hmm.
I think that's when you brought it up, and I couldn't say better things about the Minneapolis Heart Institute than what you've just said. So, well, congratulations, and all of us hope and that you continue to enjoy and grow and teach us. So coming to teaching, well, first up, thank you for contributing a very meaningful article to issue 13.2 of US Cardiology Review. I think it's a great review article. It's also progressive, and it opens up a new avenue for clinical investigation into the staging of aortic stenosis. So I will let you talk more about it. Just discussing the concept and discussing the work that you've done and Phil Jeannereau has done, and he actually is also someone who listens to the podcast. So Philippe, if you're listening, just give us a shout out on Twitter, and we'll be sure to retweet that tweet. But Joao, go ahead.
No, thank you, Ankur, and definitely have to give kudos to Philippe, for bringing up introducing this first concept, which, we're good friends as well, and I recall, him mentioning that he got a lot of pushback as well. But I think what Philippe had tried to do, in his first, publication that came out a couple years ago at European Heart Journal, was to understand that aortic stenosis goes beyond just a valvular problem. There are several repercussions that occur as a consequence of the continuous and progressive pressure overload that the left ventricle has to take. And as such, it provides some sort of a easy, bedside clinical framework that one could potentially use in terms of understanding the risk stratification for these patients. He proposed the staging system, which obviously is a cross-sectional look. It's not meaning that a patient progresses on a linear fashion from stage 1 to 2 to 3 to 4. But nonetheless, it is a way to understand that when they present with not only the severe aortic stenosis, but damage that has gone beyond the left ventricle now, for example, into the tricuspid valve or into the pulmonary hypertension, into the right ventricle, this is far advanced. And as such, these patients should be not only be intervened perhaps even early on, but also other resources need to be in place in order to potentially try to modify and continue our awareness and vigilance that by tackling just the aortic valve might not be sufficient. And so what Philippe had done before was looking at the partner data, both at patients that have received surgical and transcatheter aortic valve replacement, and classify simply into stage 0, which would be no damage, stage 1, patients that would have left ventricular changes with either increased LV mass or diastolic dysfunction or ejection fraction below 50. Then stage 2, when the disease goes from the left ventricle into the left atrium, the mitral valve, increased left atrium volumes, mitral regurgitation, atrial fibrillation. Stage 3, that would be now moving into the right side for pulmonary hypertension, tricuspid regurgitation. And stage 4 would be like the very metastatic, if you will, or terminal stage 4, in which we would have moderate to severe RV dysfunction. And he showed a very nice stepwise increase in the risk of both all-cause mortality and cardiovascular mortality for patients that had received either surgical or transcatheter aortic valve replacement. But those obviously were patients that were enrolled in clinical trials, and sometimes the criticism is that those patients would be selected. They would be obviously not representative potentially of the real world, and we decided to looking to our Tavor database that was back at the University of Pittsburgh, now looking at simply at patients that had received transcatheter aortic valve replacement, and almost 700 patients that Dr. Miho Fukui led this investigation. And using the same sort of a classification system, we wanted to expand beyond what Philippe had shown before by looking at not only now only in TAVR patients, which now represent actually the majority of TAVR has taken over surgical aortic valve replacement in this country, but also looking at the association of this staging system with both all-cause as well as cardiac-related readmissions, because it has important metric of morbidity. So it might fix the valve, they might not die, but if they keep coming back to the hospital, that might be reflective of also healthcare cost utilization and morbidity. And we saw actually, similar to Philippe, obviously in the TAVR world, there were no patients that had stage 0, but we saw this also graded increase from stage 1 to stage 4 for both all-cause mortality and also all-cause hospitalization. But interestingly, in terms of the hospitalizations, particularly patients that had pulmonary hypertension and significant tricuspid regurgitation, they had a much greater rehospitalization for cardiac-related events, which brings the question of, can we intervene and should we be intervening in these patients earlier? And could there be other strategies beyond TAVR that could be used to modify that risk?
Yes. So thank you for just going over the work that both Philippe and you've done. Just for the audience and for the listenership, I would guide them to this article that you've published with Miho. And what we are referring to is Figure 1 in the manuscript, which is, I think, a figure which I think all of us should have handy, because I think after Philippe published that paper and, after your work was published, which also looked at readmission based on the staging system, I've started using the staging system in my clinic notes when I'm seeing patients in valve clinic for aortic stenosis.
Yeah.
And, like in the work that you've done, I think a vast majority of patients that we're seeing are stage 1, meaning that they do have some degree of left ventricular hypertrophy.
Uh-huh.
But I think for the audience, I think a couple more objective parameters for classifying someone in stage 1 would be evidence for left ventricular diastolic dysfunction. So, Joao's paper, that's E to E prime of more than 14, and or left ventricular systolic dysfunction, which is an ejection fraction of less than 50%. And then, like Joao said, for stage 2, it's the left atrial volume index more than 34 cc's per meter square, or atrial fibrillation or moderate to severe mitral regurgitation. For stage 3, again, like he explained, it's pulmonary hypertension. So that'll be more than 60 millimeters of mercury systolic pulmonary artery pressure, or moderate to severe tricuspid regurgitation. And then stage 4 is when you have moderate to severe right ventricular systolic dysfunction. So, Joao, I'm going to ask you a futuristic question. It's something that you and I have discussed when we've met in conferences. And it's something that you actually have mentioned in this paper as well, in the section on future directions, which is quantifying the degree of myocardial fibrosis, particularly in a subset of patients which tends not to do that well. And, you and I both know what I'm talking about, and that's the patient population with low gradient severe aortic stenosis. Now, whether that's paradoxical low flow low gradient or whether that's true low flow low gradient is something we can talk more about. But I just wanted to, just because I have the luxury of having you here, and who better than you to tell us about fibrosis and magnetic resonance imaging? Tell us more about that. It's an evolving area, so I'd like to learn more about that.
Yeah, no, you're very kind, and I have to definitely acknowledge the work by many others. I mean, I'm just one of the other champions here from United States, but this work has been obviously done by also another great colleague and great partner in many papers, who is Mark Dweck from Edinburgh, Scotland. And we recently had published a paper in JACC a couple weeks ago looking at the different metric of fibrosis. But I wanted to call the attention to the audience here about a couple important papers that have come out the last couple of years. One is a publication that has been now in circulation in 2018 by a multicentric study that has looked into the use of cardiac magnetic resonance imaging for the evaluation of late gadolinium enhancement. In this publication, it was using a consortium of several centers, 11 centers, and they looked into can cardiac MRI done as means of prior to intervention, be that surgical AVR or transcatheter aortic valve replacement, be able to determine who are the patients that could be a potential more greater vulnerability by the presence of myocardial fibrosis. So late gadolinium enhancement imaging has been well established in the measurement of scar. We use that for coronary artery disease. And the interesting thing about this paper is that the presence of myocardial fibrosis was very common. About 51% of these patients had infarct, had the scar. And the most common form of scar was actually non-infarct scar, so 33% versus 18%. And the presence of scar doubled the all-cause mortality, and it tripled the cardiovascular mortality. And that was regardless of the etiology, regardless whether you had CAD-related scar or non-CAD-related scar, the presence of that. And it's not only you had scar you did not have, but the quantification, the percent increase, also was meaningful. And that was the first one to show, publication by Musa as the first author, and Greenwood, John Greenwood is the last author in circulation, 2018, was the first one who brought it up to us, on a bigger cohort of almost 700 patients, the importance of myocardial fibrosis by cardiac MRI. And there's an ongoing now trial led by my colleague, who I mentioned before, Mark Dweck, that is called Evolved, which is trying to push the envelope and trying to use this marker of fibrosis. Because by the time fibrosis manifests, it might be already too late. Can we intervene, or could we be potentially triggering the intervention even prior to its development? Or even in the patients that are asymptomatic, can we intervene in the presence of fibrosis before symptoms take place? So the EVOLVE trial is looking at this by taking asymptomatic patients, scanning them with cardiac magnetic resonance imaging, and should there be presence of fibrosis, they will be randomized to the continued guideline-based watchful waiting versus early intervention. And these patients will be followed by several years. And a similar study, although without using cardiac magnetic resonance imaging, has been led by Philippe Généraux here in the United States, called Early TAVR, which is more of a pragmatic trial. Regardless of the presence of fibrosis, we should potentially intervene in these patients. And we'll be very excited to hear and see what the results of these two trials will be. I believe they're complementary, and I believe we'll be learning a great deal about that. But that's just one part of the fibrosis, Ankur, because it's for you to see what it's white, which is how we see scar on magnetic resonance imaging. You need to see what it is black. But when everything is gray, you do not have a good capability of discerning that. And this grayish would be what we call this extracellular volume fraction, or ECV, which is just a measurement of how much is the interstitium expanded. So ECV will be high in the presence of fibrosis by diffuse fibrosis from the hypertrophic process, but it could also be high in the presence of other mimickers of hypertrophy, such as cardiac amyloidosis. And cardiac amyloidosis is another culprit here that we have been screening and been identifying actually much more commonly. there are at least 4 studies that I know that have looked into different populations. They have found a very similar prevalence of this overlap of disease of cardiac amyloidosis and aortic stenosis in 1 in 6 patients. So that's not rare at all. And we are very interested in this. And in fact, we have set it up a recent multicentric registry to try to understand better what to do with these patients. This obviously has a more retrospective aspect of it, and would encourage you and the audience as well to reach out to me and participate. I think this will be a great opportunity for us to better understand when and how to intervene in these patients. But fibrosis in these patients sometimes can become quite overwhelming. Ventricles become smaller, and they sometimes present with this low flow, low gradient, paradoxical low flow, low gradient.
Yes, yes. This is a vexing patient population, and from what I've seen, these patients tend not to do well. Irrespective of whether you offer them a valve replacement procedure or not. Because like you said, I think there is an interplay of another disease process which carries a poor prognosis. So in terms of diagnostic, and let's talk about the diagnostic algorithm first. Like, what triggers a workup for amyloidosis? So, for example, if you've now identified a patient who has low gradient severe AS based on a transthoracic echocardiogram, now you are evaluating that patient in clinic. What is the next diagnostic step for you or for your team, for the valve team who's evaluating that patient? Like, do you systematically order MRIs in all these patients?
No, I don't think that we are at this point of doing this mandatory, massive screening for all comers. I think our understanding so far on these other prior registries has been seen in patients that have obviously wall thickness that is increased, and typically wall thickness above 1.4, 1.5 centimeters in thickness. One of the hallmarks of amyloidosis is a very poor longitudinal function. So even though the ejection fraction might be low norm or quasi preserved, when you look in the apical four chamber, sometimes one can spot on the parasternal long axis the heart contracts, but it's mostly on the radial direction. It's mostly the transverse, the inward direction. It loses that longitudinal up and down, up and down. And so that is one of the features of amyloid. And this poor longitudinal function will be expressed on the tissue Doppler, the S prime, if you will, both medial and lateral annula, that would be reduced, typically below 5 centimeters per second or so. So when you do that, then you potentially could do, depending on how adequate the image quality is, global longitudinal strain or GLS. And if you capture the relative apical sparing, that would be great. But the absence of that does not mean that you don't have cardiac amyloidosis. So it's specific but not sensitive enough. And so we ought to continue our vigilance. And the best next step, if you have that expertise or available at your center, I would think that cardiac MRI would be a great one. And the reason being is that it can also play out into identifying the other potential causes of hypertrophy. Could this be not amyloid, but could this be HCM? By the way, HCM-like can be amyloid. So not all amyloid is all concentric hypertrophy. Sometimes you might have asymmetric hypertrophy, which looks like HCM and could be amyloid. It could be other mimickers, like in the younger patients. Sometimes Fabry's disease. Sometimes it can be primary AL, which should be treated as a medical urgency. And if you have a good MRI access, I would suggest doing that because it also can evaluate RV function and other things. The next test, in the cardiac MRI only tells is there amyloid or it is not amyloid here. It does not tell you whether you have primary AL or you have TTR, transthyretin amyloidosis. And for that, you need to go for other testing. You got to exclude primary L with biomarkers and blood testing, and urine testing, immune electrophoresis, and immunofixation, and free light chain. But also, you need to get a technetium pyrophosphate scan here in the United States, which should be available in several hospitals. Is an old bone tracer that is relatively easy to be done. And for those patients, just the careful analysis of that, not only with planar image, but also with SPECT imaging to make sure that we don't capture blood pool. So there are some nuances, and a lot of the society guidelines, ESNIC has come up with a nice pamphlet that should be available for several practitioners on how to use nuclear imaging for the diagnosis of cardiac amyloidosis. It's much more common than what we think it is, that it used to be.
Yes, I mean, some of the contemporary registries that I've read, just the data and the reporting, I mean, I think the prevalence is anywhere between 15 to 17%. And that's not a low number. That's a lot of patients.
Right. And I think, the stakes are high now because we have a treatment for cardiac amyloidosis, although I would say the treatment is quite expensive, as you probably have seen some recent discussions on not only social media, but also on other reports. We believe that this will change as we're starting to recognize that this is not a rare disease, it's not an orphan disease as it was filed initially, but rather much more common. And as such, we need to continue to provide not only the diagnosis, but also access to treatment for these patients. And all of a sudden, TAVR for these patients might become a very relatively cheap offer, right? When we have a drug that costs $250,000 a year versus, $25,000, $30,000 for a TAVR valve, they might still derive some benefit. At this point in time, we don't have any data to support that we should be withholding treatment. They might derive some benefit, although this benefit might be reduced. And it begs the question, can we make this diagnosis earlier for these patients? And I highly encourage you to reach out to us. We have this website now. It is as-amyloidosis.net, which is really about this multicentric registry consortium, Ankur, and would really welcome you and other colleagues to also look back at your hospital. Have we made this diagnosis before, and do we have these cases? And I think for this multicentric collaborative registry is how we're going to try to at least get some glimpse of what to do with these patients.
Yes, no, thank you for bringing me up to speed with the registry. I'm going to reach out to you, in person.
Yeah.
And try and collaborate, because it is, like you said, it's a very important question, and we definitely need an answer as to how to best manage these patients. Well, Joao, thank you for a fascinating discussion. I know we've been trying to set this up, and this is late in the day, so thank you for making the time to get this recording done.
Absolutely.
Just closing remarks. Thank you. No, thank you. It was just an absolute treat to have you. Just closing remarks for the audience and for our listenership. I just wanted to thank everyone. And Joao, you and I have talked about this off the record, but I just wanted to thank everyone, including yourself and everyone else who's been tuning in to listen to us. We really value your suggestions, your feedback, your support. You've allowed us to grow and evolve, and you've given us so much love, to me in person, as well as, to our team on social media. And I just wanted to share that the podcast Parallax has won the 2020 Scholarship in Teaching Award from Case Western Reserve University School of Medicine. It's the medical school that is in the city of Cleveland, and it has the Cleveland Clinic is one of its affiliates, as one of the flagship affiliate teaching hospitals. So I just wanted to use this opportunity and this platform to share this great news with all of you, and Joao, I've shared this news with you in person.
That is phenomenal. And again, congratulations and kudos for you to start so many other initiatives. I really love how dynamic you are, and you have touched so many lives, not only through this podcast, but through your other initiatives that you have started. And I applaud you for continuing this effort, going beyond just seeing the patients and treating patients, but caring for us physicians. And I think this is a testament of how teaching can occur beyond just the science itself, but us as human beings.
Yes, I again, I would not have been possible without the guests that we've had on the show. Incredible guests like yourself and many others, that have blessed us with their time. So, Joao, thank you again very much. From the bottom of my heart, this has been a great discussion, and we'll have a lot more in person. So, thank you. Thanks again.
Likewise. Thank you so much again, Ankur.
Dear cardiologists, we want to make this podcast about you and for you. So please email us your critical thoughts, comments and questions at podcast@radcliffe-group.com and visit uscjournal.com for more information. You can also follow us on Twitter, LinkedIn, Facebook and Instagram at Radcliffe Cardiology for daily updates. Join thousands of cardiologists and become a Radcliffean by registering to radcliffecardiology.com. You will receive regular newsletters and gain access to hundreds of expert interviews, educational webinars, clinical cases, and peer-reviewed articles from our 6 medical review journals on general cardiology, interventional cardiology, arrhythmia and electrophysiology, cardiac failure, and vascular and endovascular surgery. Thank you.